of they throw a lot of CT slides on there, and like you got to find your way around them. And we'll put this here. I feel like.
What is this, man?
Okay, so
This a neck? What?
yeah, so they throw a lot of CT slides on there, right? So all you have to know is like I gave you like 5 or 6 key slices. So if you guys know these 6 slices and like cold, you'll be good with CT. You'll be able to recognize anything up and down below that. But you got to know these few slices of CT like clean. You know what I'm saying? Because if you know these, they'll guide you can find your way around any other slices. So in this one, um, this is like almost your shoulder level, like because I can see the humerus right here. So let's go through these real quick, Kenny. So what's one?
Trachea.
Trachea. Two?
Mhm.
What's two?
Oh, I don't know what two is. What is two?
So at this
What's
level,
thyroid?
thyroid, yeah, and they're saying it's
Yeah.
like lit up light because uh, it contains a lot of iodine. So, like I said, I'm gonna give you these few slices of CT, but just know these 6 slices cold, and you'll be good. Okay, next.
All right.
All right, one is what?
Mm. Sternum or something?
Yeah, I think it's the manubrium. Um,
Newborn. Okay.
yeah, yeah, manubrium is part of the sternum. Yeah, and then so 2 and 3. So 3 is gonna be your brachiocephalic artery. Wait, let me see. Let me make sure. Yeah, artery is more medial, right? So yeah, 2 is gonna be your brachiocephalic vein. 3 is gonna be your brachiocephalic artery, and 4 is gonna be your left brachiocephalic vein. What's 5 and 6?
Yo, I don't know, man. 5 and 6. I'm
What's
cheating here. I'm looking at the answers.
Yeah, because you know
That's
how
why
like
I'm so
because on the left side there's no left brachiocephalic artery, right? It's just like carotid and subclavian.
Yeah.
Only the right side has a brachiocephalic because carotid branches off of the brachiocephalic on the right side. So
Right.
5 is gonna be your carotid artery, left common carotid, and 6 is gonna be your left subclavian, and 4 is gonna be your left brachiocephalic vein. So yeah, I'm gonna go through like 4 more. Just know these like real good. Okay, next. What do you think 2 and 3 is? You already know.
2 is the aortic.
Yeah,
3,
3.
I think. I'm
What
gonna
is
go.
it?
I'm gonna say SVC again,
Yeah,
man.
it's gonna be
Huh?
SBC. And then that black hole is what?
Black hole probably. It's still trachea. It's probably still
Yeah,
trachea, right?
yeah, because it hasn't bifurcated yet. Okay,
Yeah, it's
now
fabricated.
what's let's see. What do you think 1 and 2 is at this point?
1 and 2, right and left bronchi,
Yes, sir.
respectively.
Yes, sir. And
Uh,
then 3.
oh, 3. What is that, man? Descending aorta? Is that descending aorta?
I think so. Let me see. Let me think. Superior vena
I don't know
cava.
what else that could be.
Yeah, I think so. It's got to be descending
I think
aorta.
it's aorta.
Um, what
Five
about
is 5 or 4.
yeah? What is 5?
5, yeah, I think that's esophagus because it's
Esophagus. Yeah.
pretty dark,
Mm-hmm.
right?
4.
And then 4 is the bronch pulmonary arteries.
Yeah, main pulmonary trunk. Yep.
It's splitting like that. Main pulmonary trunk. Right, right.
Yeah. So you think this is the ascending aorta, and
I had to guess that is the ascending aorta.
it has to be right. And at this point, I guess SV is like too deep in to see the SVC. So we're like deep into the heart. All right. What about here? What's 2, 1, and 2? Well, just get your sides right, and then I think you'll be good.
Am I? Is that the heart? Is that the
Yeah.
left ventricle or right ventricle? there.
So yeah,
Yeah.
so this
Wait.
side is the left side,
Hmm.
right? So this is gonna
Yeah.
be your left ventricle because it's the left side, and this side has like thick walls, is what they're saying. And then two is your right ventricle, and then three and
Hmm.
four is just pulmonary arteries and veins.
Uh,
So question, Kenny, like on a chest
okay.
X-ray, right? Those like little white things you see in a black lung, what are those?
Those little white
Yeah,
things you see
like
in the
on a
black
chest
lung.
X-ray, like you see like these markings,
Right,
right?
right,
What are
right.
these? What are all these things?
Mm. Some vasculature.
Yeah, pulmonary arteries and veins, right?
Yeah.
Yeah,
Uh-huh.
what color do you think like airways would be? Bronchioles and like alveoli and
I'd expect
respiratory.
them to be dark, man.
Yeah, like
So they
this,
got
right?
air in it. I don't think I should
Yeah,
see them.
yeah, it's just gonna be like
Mm-hmm.
that. That's all I'm saying. So anything you
Uh-huh.
see like lit up like that is like pulmonary arteries and veins.
That
Okay,
makes
and then at this
sense.
point, this is like uh the
Yo.
liver, this is the
Oh, I
liver.
was gonna say, like, what is that?
Yeah, we're
Okay.
like really deep
Yeah.
down, and then this is like descending aorta. So like just know these like few slices, and then for CT, and you'll be very good. Next, they talk about lymph nodes a lot, and like they'll give you a CT slice, and they'll be like, what is that? And then you'll be like, oh, is it a mass? But they're like, no, it's a lymph node. But then like, how would you know like there's a lymph node there, right? So
Mm-hmm.
lymph nodes, like these are the four areas, like where I have A, B, C, and D. These are the four areas in your chest where you have lymph nodes that, and then whenever you're looking at CT, if it's one of those areas and you see something that looks like a lymph node, you'll be like, oh, that's a lymph node. So lymph nodes are like it says right here, they're oval and they're discrete. So like as far as arteries and veins, you know how they come from like a large artery or a vein and then they taper off. But lymph nodes, there's not going to be any tapering. It's just going to be like something like discrete. And the center of like lymph nodes, they kind of appear like a little bit low density because they have fat in the center. But other than that, if the CT has contrast, the blood vessels will be lit up. The lymph nodes won't be as lit up. So basically, they're just gonna look very discreet. They're not gonna taper off like blood, and they're not gonna be lit up on a CT scan. Most of these CT scans they show you, they're all like contrast enhanced. This is what I've noticed. So these are the four areas where you're gonna see like lymph nodes in the chest. So they're gonna be like next to the trachea, like you know how that black circle. So if you see anything around that, and those are called paratracheal lymph nodes, you're gonna see it underneath the aortic arch. So I think that's the aorticopulmonary lymph nodes, and then you're gonna see like where the trachea bifurcates by the carina, like right underneath it and in front of it. And lastly, you're gonna see it during the hilum. So I'm gonna show them to you. So I highlighted all those four areas in like different colors. So you're gonna see it along the trachea. These are your paratracheals. I said you're gonna see it under the bifurcation under the carina. You're gonna see it under the aortic arch. That's your aorticopulmonary lymph nodes, and you're gonna see it near the hilum. You see these? So those four
Mm-hmm.
areas: paratracheal, under the carina, around the hilum, and under the aortic arch. Okay. All right. So like this one, this is the trachea, right? So these ones
Right.
around it, what do you think these ones are called? Going to be called around the trachea?
Tracheal, peritracheal nodes.
Yeah, and you see how they're not as lit up as like blood vessels, right? And then their center is kind of like
Mm-hmm.
low density. Um, they're just like a little clump of discrete. They're not like vessels. They're like just oval and they're just like
Mm-hmm.
these clumps. They don't look like you'll. And then they one thing is that they look like the same color as like muscles on a CT. Like if you look at it, they kind of look
Right.
similar to muscle colors. Okay,
Uh-huh.
next, you see this is the ascending aorta and this is the descending aorta, right?
Uh-huh.
So right underneath it, you see another clump. What do you think that's gonna be?
The ones that say the aortic. I don't know, man.
Yeah, the
I don't know what to call them, but
aorticopulmonary. As long as you know where they are, you'll be good.
yeah.
So it's sitting right between the ascending and descending, right underneath it. And then one is like in this, and then you see how right here before it's like trachea circular. Right now it's like kind of like elongated. What do you think is happening?
About a split, man.
Yeah, it's about to
We about
split.
to
So
enter
right in front
Carina.
of it. Yeah, right in, like I said, it's gonna be right in front of it. Let's see what it's called. It's the one right here, inferior tracheal or carinal nodes, where they bifurcate right underneath that. Um, let's see. Yeah, in front and beneath the tracheal bifurcation, known as carinal lymph nodes. So, uh, right, right here. So where they're bifurcating in front of it, these are gonna be the carinal lymph nodes. And at this point, it already bifurcated, right? So these are the ones that was underneath that carina. So these are all still those carinal lymph nodes. But now, uh, what are these two black things like separating from each other?
Bronchies, right?
Huh?
No?
Bronchi, yeah,
Bronchies?
bronchi. So the ones that are surrounding the
Yeah.
bronchi as they're going away, those are gonna be your hilar lymph nodes because, like if you look here, these are the ones that are kind of like going along with the bronchi. Okay,
Oh,
they're your
gotcha.
hilar nodes.
Hmm.
So those are the areas where you're gonna have lymph nodes. You're gonna have it around your trachea. Those are gonna be tracheal lymph nodes. Underneath the aortic arch, aorticopulmonary lymph nodes. You're gonna have it in front of the carina, carinal lymph nodes underneath the carina, and then you're gonna have it
Uh-huh.
surrounding the bronchi as they go off. Those are gonna be your hilar lymph nodes, and they kind of look like the same
Right.
uh, color contrast as like muscles. All right. So showed you how to look at the fissures to just like come down to what lobe it's in. I told you about the silhouette sign to distinguish between upper and lower lobes based on whether it's silhouetting the heart or the diaphragm. And then I showed you where the lymph nodes are and those key CT slices that'll like help you with other any other CT slice of the chest. If you know those, I think you can work your way around it. All right, now the first one is like pneumonia. So there's like three basic things like you need to look in a chest X-ray. If you know how to distinguish those three, like everything falls into these three things. It's either like uh, consolidation, or it's like plural or consolidation, and then pulmonary edema or fibrosis. Everything falls into those three categories, and if you know how to like distinguish those three, like all the pathologies, they fall in one of those three categories. So pneumonia,
Consolidation.
yeah, consolidation, consolidation, pulmonary edema, and then fibrosis.
Uh-huh.
So consolidation is basically, you know how you have the alveoli, right? The airspace, the
Uh-huh.
airspace border, so inside the alveoli. So in consolidation, that's where you have to know like where it's always like fluid, right? Like either whether it's like pus or blood or transudate, it's always fluid. You got to know where the fluid is. So in consolidation, the fluid is like the actual space where the perfusion is happening or the diffusion is happening, like within the alveoli, right? That's where
Hmm.
pneumonia, like the the bacteria and stuff accumulates, like it's like the actual alveoli. So the cool thing is, because the alveoli are the parts that are being consolidated and they have stuff, fluid or purulent fluid, whatever it is, it's in the alveoli, right? So that's the part that's consolidated. That's what gives this whiteness. All of this is whiteness. So, but the thing is, everything before the alveoli, like the respiratory bronchioles and terminal bronchioles and stuff, they don't have fluid in there in consolidation. So there's this thing that happens. It's called an air bronchogram, which is basically you have consolidation, right? But you see like these like it's very you have to really try and see. So this is you see where the area is consolidated, right? In pneumonia, the consolidated area it just looks like fluffy and it doesn't have a discrete shape. Whereas like lesions and everything else has a discrete shape. It's just like one little area of like snow fluffiness type thing going on, and you can see where it's at, right? It's right here. You
Uh-huh.
see it, right? It would probably
Yeah.
be which lobe do you think it would be?
It's the upper lobe.
Probably, right? Like if we were to
Yeah.
count like one, two, three, four, five, six, lateral border, hilum. Oh, that's good. So so that's good because you see like this right here, this would be the fissure, right? You see how it just
Uh-huh.
ends bluntly there? That's because
Yeah.
the fissure is containing it there, and you can see like that's another
Mhm.
one. Now you see like how that tip I gave you to distinguish where the horizontal fissure is. You can see it because it goes from the hilum to lateral border or axillary border of the sixth rib. And then so anyways, so in consolidation it looks like that. But if you look at it, do you see like these little black lines in midst of this consolidation? Like right here. You see
Yeah.
that? Right here. You kind of see it, right?
Uh-huh.
And then this little thing
Uh-huh.
gives you this diagram. So
Uh-huh.
what's happening is basically the alveoli have consolidation, but those respiratory bronchioles and terminal bronchioles, those still have air in them, so they still look black. Normally, everything is black. The alveoli is black, the respiratory bronchioles black, terminal bronchioles, so everything is black. So normally you don't see anything. Normally you don't even see these like respiratory bronchioles and stuff. But now, because the alveoli are consolidated, it gives you this white background where you can see these respiratory bronchioles and terminal bronchioles. So this is called air bronchogram. You see that? So if you see like this little area of fluffiness consolidation, but you see little black linear lines within them, that's pneumonia. That's consolidation, because where you have the consolidation in the alveoli, but the respiratory bronchioles and the airways are still clear. They still have air in them, so they look black against a white background. So now you can see them. Do you get what I'm saying?
Yeah. Mm-hmm.
So like right there, so like this is a consolidation, but if you see these like linear lines, those are the airways. So air bronchogram is a clean cut sign of like pneumonia consolidation. Oh, and one other thing
Mm-hmm.
is like if uh like the pneumonia, the consolidation usually gets like worse as they go down because of gravity and whatnot. So like as you go down, you'll see like right by the border, that's where it'll be like most heaviest. So like as you can see right here, but the horizontal fissure is like containing this like pneumonia. And the CT scan is like really shows the air bronchogram really nice. So if you see right here the alveoli, that's where the consolidation is, but the airways, the respiratory bronchioles and whatnot, they still have air in them. So now with against the white background, they really show up. So you get what I was saying earlier?
Yeah.
Okay.
Is this the right lobe? Okay.
Yeah. So
Got it.
right. And then
Mm-hmm.
consolidation, like so because it's fluid everywhere, so the fluid sinks. So the lower borders of any consolidation is going to be heavier. Um, and obviously the patient's clinical history. If you see air bronchograms and then they have fever, cough, you can put it together. Then it just leads you to pneumonia. But the air bronchogram, that's like a clean cut sign of consolidation because you have fluid in the alveolar spaces, but the airways are still clear. So now the airways are being highlighted where normally everything is black and you don't see anything, but now you can only see these black airways. So that's consolidation. Okay. So this is another like more widespread consolidation affecting both lungs. But if you look at it, like even if you look at this area, not anywhere else, you see these little black lines inside amidst the consolidation, right?
Yeah.
Just like if you can't look at
This.
it, it's like step back a little bit. If it's like a lot of whiteness and you see like these linear black lines in midst of the whiteness, then those are
Uh-huh.
that's air bronchogram.
Yeah. Right.
That indicates towards pneumonia. Whereas like pulmonary edema is you have fluid, but it's not in the alveolar spaces. It's like it's different, so you don't really get the air bronchogram, which I'll show you. But if you see like this, like
Where
consolidation,
is the fluid in pulmonary edema, yo?
hmm?
I never understood that. Where is the fluid in pulmonary edema?
Yeah, so I'm gonna show you. So like, it's more like in the inter, it's in the interalveolar space in the beginning. But if it gets really worse, they say then it can like in ARDS. I'm gonna get into this. Like in regular pulmonary edema is caused by what?
Heart failure could be,
Heart failure, right?
just
Heart failure,
increased
yeah,
hydrostatic pressure.
exactly. So in regular heart failure or pulmonary edema, the air is like wherever, because you know how those blood vessels run in the alveolar interalveolar septums, right? So the fluid first accumulates in the interalveolar areas, but if it really increases later on, it gets to that. But in normal pulmonary edema, the fluid is just, I'm going to show you, it's just in the interalveolar spaces, not in the alveolar spaces, but amidst the alveolar space. I'm going to show it to you. But in ARDS, where the lungs, like the way I think of ARDS is just the lungs, they're just taking a beating. Like in ARDS, you get like signs of pulmonary edema, like you have interalveolar edema, but you also have edema inside the alveoli because it's like the fluid is not only leaking out of blood vessels, it damages like the blood vessel, but the fluid is also being accumulated inside the alveoli. But here, I'll show you in a second. So the next is, like I said, is like pulmonary edema, right? So the pulmonary edema, like the classic sign is like bat wings, bro. Like you see these these areas where it looks like like
Uh-huh.
congested blood vessels centrally.
Yeah.
So the why do you think this bat sign presents? Can you tell me? But even before that, you said like it's another thing that gives away like regular pulmonary edema due to congestive heart failure is like what do you think that is like other than the bat sign?
What? Wait. Uh. Wait. Asking about like why the bad sign is there and stuff.
That too, but like another thing is
Or what
like
do you
if,
mean?
if they have congestive heart failure, right? It's
Uh-huh.
because they um, have left ventricular failure, right? Because
Yeah.
the left ventricle can't pump the fluid out, so they back up into the lungs, and that's how you get pulmonary edema. So in with pulmonary edema related to congestive heart failure, you're also gonna see like left ventricular like dilation of the heart, you know, like this area. So like the heart's also gonna be enlarged. Is basically what I'm
Uh-huh.
getting at. Like um, that not only you're gonna see like the lung signs, but the heart's also gonna appear big. Like especially the left ventricle. You see, like here, the left ventricle, like normally it doesn't go that far out. But why do you think the bad sign happens though?
Because of the edema, right? Just the backflow of everything,
Yeah, so
and
like
then that's like.
so whenever the fluid, like let me see. Okay, so these okay, you see like these interlobular septa,
Uh-huh.
right? So in this case, normally you know how the fluid and consolidation happens in the alveoli, right? In this one, normally this is how like the blood vessels run. So the fluid accumulates in this whole area. You see like these little clumps of
Uh-huh.
areas. That's where fluid accumulates.
Right.
The only areas where fluid isn't accumulated is like it's like these septas, you know what I'm saying? That's why you get those curly B lines because this
Uh-huh.
fluid, but these like little lines that are like separating each inter lobules, you know, interlobules, interstitiums, like they're separating them. They're containing all this like area of fluid. These are the things that are giving off those curly B lines. You get what I'm saying?
Okay, got it. Yeah.
But the reason what I was saying is like so because now you have fluid leaking out, right? Like near the capillaries from the pulmonary vessels, right? So what happens if an area of lung gets hypoxic in the lung? It's
It
like
constricts.
it vasoconstricts, right? So all these
Yeah.
areas that have fluid, they're hypoxic, so they're vasoconstricting. So because of that, you have venous congestion and centrally. Like all these are pulmonary
Uh,
vessels. So all because all these areas are vasoconstricting, now you have venous congestion centrally. And then
uh-huh.
another thing is like if you look at a regular chest X-ray, like let me see, it goes along what we just said. Where do you think the vessels are gonna be more? Where do you think the vessels are gonna be more dilated and like peculiar, like up or down? Like where do the vessels look more like prominent?
Down, I would say, just
Down,
because of
right?
better
Because
flow. Yeah.
there's more blood flow there, right? Because it's gravity. And if there's more
Yeah.
blood flow, there's more oxygen. So those vessels and lungs, what happens if there's more oxygen? It's just opposite of what you said.
What? Sorry, can you repeat that?
Yeah, so if there's
You said,
more, if there are vessels because of gravity, there's more blood flow in
uh-huh.
the bottom areas of the lungs. So because there's more blood flow there, there's more oxygen there. What's going to happen to those
Uh-huh.
vessels?
Gonna dilate, right?
Dilate,
I saw
right? Because
that.
if there's
You
less
saying there's,
oxygen,
yeah.
they vasoconstrict.
Hmm.
That's why in a lung chest X-ray, pH chest X-ray, the the vessels in inferiorly towards the diaphragm, they're more prominent. You see that
Hmm.
compared to the top, because there's more blood flow there.
Yeah.
So these vessels are vasodilating. But in a pulmonary edema, where do you think these like fluid that's leaking out of capillaries, where are they going to accumulate? Top or down?
The bottom.
Bottom, right? Because the fluid sinks. So in this
Yeah.
case, because there's more fluid down here, now this is like a hypoxic region, right? So in pulmonary edema, if you see like vessels and the top of the lung look equally dilated or equally peculiar as vessels down below or even more dilated, that's pulmonary edema because there's fluid accumulating down below. They're hypoxic. Normally these vessels are going to be the vessels down bottom. They're going to be there should be the more peculiar dilated ones. But in pulmonary edema, because fluid collects there, this is becoming the hypoxic region. So the vessels on top, they look more distinct. You get what I'm saying? Which is what you see.
Okay.
If it's equal to the vessels down bottom or greater, more distinct, then it's pulmonary edema. That's another sign. Which is what you see here, right?
Hmm.
Compare like the
Yeah.
vessels up top, they're more dilated. And I showed you like where these curly B lines are, right? They're like those interlobular septas. That's
Yeah.
okay. And then, yep. Okay, now ARDS. So what happens in ARDS, Kenny?
You got
What's the
alveolar
pathophysiology behind
damage
it?
and shit.
Yeah,
Got alveolar damage and shit.
it's basically toxins, right? Like that causes like I think it
Mhm.
causes like capillary damage and it just causes like fluid. I just think of it like it's just like your lungs, they're just taking a beating,
Yeah.
So
Hmm.
in ARDS, you're gonna have symptoms of both pulmonary edema and consolidation. And that's what I'm gonna show you right now, which is so um So in ARDS, those I think it's basically because you have it's like really bad infection and you have release of inflammatory mediators like interleukin 1 and they this is the reason why it has symptoms of both pulmonary edema and consolidation because in pulmonary edema it's fluid transitive fluid leaking out of capillaries, right? From the blood pressure, right?
Right.
Yes. It's pulmonary edema is not there's no infection, right? It's just like because of the blood pressure, the fluid is leaking out or like out of like regular capillaries, right?
Yeah. I
And
gotta
pulmonary,
shit.
huh?
Wait, so pulmonary edema is only caused because of a increase in pressure?
Yeah, because the
It's not
pressure
because of an
blood flow,
infection.
like those vessels can only handle so much. Like the hydrostatic pressure increases like tremendously because of backup,
Uh,
you know.
I mean,
So these capillaries are
okay.
leaking out fluid. So in ARDS, interleukin 1 damages the capillaries, the alveolar capillaries. So because of that, it's kind of like similar to pulmonary edema because transitive fluid is leaking out. But also, there's like something about um, like the neutrophils, they go into the alveolar spaces and they damage like the pneumocytes 1 and 2. And because of that, because they're causing damage in the alveolar spaces, it's kind of like pneumonia because now that causes fluid buildup within the alveolar spaces. So because of that, ARDS has signs of both consolidation and pulmonary edema because one alveolar capillaries are being damaged by interleukin 1 which causes fluid leakage, but also neutrophils are damaging the actual the diffusion area, which the area that normally gets affected in pneumonia is also being affected. So In ARDS, you're gonna see like signs of like pulmonary edema, which is like um, you're gonna see like obviously like you're gonna see the air bronchograms because of the consolidation, but you see how it's very like diffuse as opposed to like
Right.
regular consolidation. Let me see. Hmm.
I mean, it's hard to tell. I mean, it's pretty similar to just pulmonary edema as well. Can you really, say, one is pulmonary edema and one is, ARDS just by chest X-ray? I don't feel like you could you just say, could you be calling one, this
Because
and that
sometimes pneumonia
just from
causes
a chest X-ray?
ARDS, right? Like if you have really
Right.
bad
Yeah.
pneumonia, it could cause ARDS. Um, but the thing is now you're gonna see whereas normally consolidation is like in one specific lobe. If
Hmm.
you see those like curly B lines or increased venous increased vessels on the top of the lung, now you know like it has kind of like symptoms of pulmonary edema. But also like in this one, if you look here in this like right this area right here where I'm circling, it's like a consolidated area, but I see like little black spots, which is like air bronchograms, which is like signs of consolidation. Even like here, I see like consolidation, but I see little black linear black areas, so which is air bronchograms. But the more like this like diffuse like because usually consolidations is not that diffuse, like in both lungs like that. So this whole diffuse presentation that looks more like pulmonary edema. Um, and like I think you can like see even curly B lines too. That's coming from the alveolar capillary damage. But I definitely see like even here, you see like oh this is a good one. You see right here, Kenny, where I'm circling. You see like there's like consolidation, but you
Wow.
see this like air bronchograms, these two lines.
Yeah.
Yeah, that's a good. So like definitely consolidation, but then this whole like diffuse presentation where also like I don't see the costophenic angle right here. So that's like that's pleural effusion. So that's definitely like fluid accumulating, which I'm gonna go into in a second. But this whole diffuse presentation that kind of looks like pulmonary edema. But the one thing about that this is not pulmonary edema, that pulmonary edema, because the heart is causing it, is very symmetrical. Both sides look very similar, you know what I'm saying? Because it's just pressure. There's pressure everywhere. And
Right.
and then also this like venous congestion is more central, whereas like in ARDS it's like not as like as symmetrical because it's not like the pressure's not high everywhere. It's just like wherever there's like alveolar damage, there's fluid leaking out, and you can have like curly B lines also because uh because of that fluid. But in this one, like you not only have fluid in the whole like interalveolar interstitium, but also in the like actual air spaces, like you see with consolidation. You get what I'm saying?
Yeah.
All right, cool. And lastly, fibrosis. Fibrosis at the end of the day, to me, it just looks like a staticky X-ray, man. It just looks like if you take an X-ray and it looks like it was, how you get like old school TVs with antennas and it's like staticky, picture's not
Yeah.
clear. That's what fibrosis is. And it's basically because like you get this like it looks like almost like you get this thin veil over it, and it has like this mesh like look to it. But one thing is that with fibrosis, it's more worse in the peripheries. And another thing is because like these lungs are being fibrotic, normal structures like vessels or like hard borders, where they're supposed to be look nice and clean, it doesn't look all. It's not like in consolidation where I said like with the silhouette sign where you can't see the borders. You can still see the borders, but it's like almost like fuzzy. So that's it. Like it's because of the lungs where normally it's supposed to provide like a clean black ground for all these structures. Now it's like fibrotic and has like more of like more it has a more normally lungs are supposed to be black, but because of fibrosis, it has like a little more whiteness to it, like the mesh. So because of that, it creates more like the hard borders and stuff, makes it look more fuzzy. Also, like blood vessels, like pulmonary vessels. that are normally supposed in areas of like fibrosis, hard to see that too because of the fibrotic area. Like I can see vessels here, but in areas like where it's like fibrosis going on, it's really hard to see the um yeah, it's really hard to see the pulmonary vascular markings. Are they less distinct?
What's that? What's that? What is that clear? I don't know what use the technical term is, but it's much clearer right about the clavicle. Or yeah, it's like
Oh,
the
like
clavicle.
right here? Is that associated with fibrosis?
Yeah, yeah.
Oh
I don't
wow.
know. I'm just
I
wondering
didn't
what is
know.
that,
That's a
yo?
good point. Who's they said that in RRE?
No, they say that in the RE. I'm just wondering. I saw that and I was like, what is that, yo? Why? Like everywhere else, I see that staticky sign, but there it's like clear. It's
Hmm.
weird.
I mean, this area even here, like even like the apex, bro, because like I said, gravity, that the apex is like one of the most like least like the most hypoxic areas because like that's the area where it's just like it's gonna have like least amount of blood flow because of gravity. So in that area, the vessels are gonna be really vasoconstricted compared to the bottom. The vessels should
Mm-hmm.
get more and more engorged and distinct as they go down. But but yeah, but definitely the hard borders and stuff. It looks fuzzy. That's all fibrosis is. Yeah, it's like interstitial pneumonia, um, like mycoplasma pneumonia. Um, what else causes interstitial pneumonia? But yeah, it provides that mesh-like fuzzy appearance. And then
Right.
obviously you've seen like the whole haziness. Definitely no air bronchograms like you see with consolidation. This is not air bronchograms, right? Because, like I said, in air bronchograms, those airways they're black against a white background, right? These are vessels. You understand that?
Right. Mm-hmm.
Yeah. Pleural effusion is easy, man. Like basically, at the end of the day, you just lose claustropenic angles because that's where fluid accumulates. Um, And do you know what the meniscus sign is? Can you like?
Meniscus sign?
Yeah,
Nah.
it's like when like
Yeah.
you see like it's like if there's fluid like they kind of like how fluid sits, it's kind of creates like
Right.
this little like there's like a
Meniscus.
circular structure, like the fluid's gonna
Yeah,
have this
yeah,
meniscus. That's basically what it is. Like it kind of has just like
yeah. Mm-hmm.
this like little curve to it, which is like meniscus sign. That's what they say. Because if it's not like if it doesn't have that, then you could be like, oh, maybe it's not fluid, maybe it's something else. Like the diaphragm is pushing up, or there's something there. But like if it has a meniscus sign, it just tells you like there's fluid in there. That's all.
Right.
You just lose your claustropenic angle. If it's one side, it's probably more likely infection or like something affecting that lung. If it's both sides, it could be like pulmonary edema or something. Good. You good, Kenny? I'm gonna take that as yes. Um,
You hear me?
yeah, but I just lost you for a second.
Oh, okay.
But da, 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 da. So in this one,
It's
it's like a really
okay.
large pleural effusion, man. That's pretty much all
Damn,
it is.
crazy.
Yeah. Yeah. Okay, and then lung nodules. Um, now you know how to localize the lesions. So in this one, we can't really tell like if it's where it is because on the left lung, you have to see like if it's above or below the oblique fissure. And you can only see the oblique fissure like on a lateral, like I said, T4, T5 to anterior 1/3 of the diaphragm. But like it's not causing silhouette sign of the heart or the diaphragm, so we can't really say. But anyways, if it's a nodule, if it's like spiculated or if it's like has a lobulated look to it, then it's suggested of malignancy. Um, and then look for like lymphadenopathy. And sometimes like if there's a something going on here, look areas distal to it because that area is like in this one. I think there's like less vascular markings, or it could cause like collapse distal to that area. That's basically it. So and then here, I think so. This is like a that's what they call as a cavitating lesion. So center is like a little bit darker, and then you could have like fluid levels within these lesions. So I think this is what it is like this whole thing is some kind of a lesion, but this is the cavity and this is like fluid collecting up there. So this is air, but up until here it kind of has like
Right.
a little bit of meniscus sign, which is like here. Actually, this one has multiple. You see, one, two, three, four. There's another meniscus
Yeah.
sign. You see that? But so like with these like cavitating lesions, like the if the walls of these lesions are really thick, that's more likely that it's malignant. But the cool thing is, if you see like these cavitating lesions and you see like this like little white ball within the cavity, that's what do you think that is?
Aspergillus or something, right?
Yeah, aspergilloma, which is like right here. You see this cavity, but you see this white
Oh,
ball inside. Those guys are just like opportunistic as hell, man. Like something leaves a cavity and they just find a home in there. It's messed up.
okay. Wait, would this be a good X-ray? What are, those criteria that what's his name? Astro, whatever his name is, gave us about like what's a good X-ray.
Like what?
So
Like
I
a
can't.
certain
This X-ray just looks different from other X-rays. I think like it's like the X-ray is just too strong. I can't even tell what's. It just looks different. You know what I'm saying?
I think what you're supposed to see is like the lungs are supposed to be black, but the bones are supposed to be white. Like if they don't put enough, I call it juice, like if they don't put enough juice in the
Yeah.
machine, then the lungs look
Mhm.
white, like, and then the heart and then everything else looks like really white. But if they put
Yeah.
too much juice, like even the bones start to look a little bit black. But in this case, like
Yeah.
this is I think it's just like real high def. But in this case, like if they go put too much juice in, like even like these bones and stuff will start to look black. But the thing is, like you won't be able to see these pulmonary vasculars, vessels,
Yeah.
because they'll wipe them out. It's just
Mhm.
too much juice. All right. So in this one, um, basically this one has a really big, like really thick wall. It's a cavitating lesion, but with a really thick wall. You see that? So this is more likely of being like malignant. And then, yeah, and that's it. Okay.
Mhm.
Next, mesothelioma. What do you think is like? What do you think is one thing is that's like peculiar about mesothelioma? Do you remember? Like just cause of one
Just those
thing, other than it affecting the lungs. It like what was one thing that's kind of like.
mesothelioma. It's just on the perimeter, right?
Yeah, yeah. So it's in the perimeter and it causes like pleural thickening too. So in this
Uh-huh.
one, like the whiteness, it follows the boundaries, and sometimes it can cause, because it's cause of pleural thickening, can cause like loss of volume. So as you can see, this lung is like a little bit smaller than this lung, but what we're seeing right here basically is like pleural thickening here, yeah, and like here too. But that's what I was gonna say. Mesothelioma is associated with pleural thickening, and if you see it on, oh, that's it. Okay, that's basically, I guess, it. Uh, there's nothing else to it. It's gonna have like consolidation, but main thing, pleural thickening. All right, miliary tuberculosis. So this is like so you're gonna see like these shadowings right now. Normally there's like shadowing present, but it's more central, like, and these are vessels. But if you see like shadowings like more towards the periphery, and all these little markings, they look like very uniform, discrete, and on both sides they all look similar. That's more like that's more indicating of like miliary tuberculosis. And with TB, usually you get like lymphadenopathy, hilar lymphadenopathy, which is what you see here. And it's like, but yeah, like you get these like shadowings, Like I said, with vessels, with lung vessels, you can get shadowings too, but not so peripherally, and they're not all very similar looking. Like, but these are all very discrete looking and uniform. And then here we have multiple, tuberculosis can cause cavities. So, there's another reason why like aspergilloma can happen with like, tuberculosis patients. So basically multiple cavities are seen here in tuberculosis. What, what do you think this is, Kenny? This little thing that they zoomed in there without reading
The
the,
little white
huh?
the little white dot.
Yeah, what is
Yeah, I
that?
don't.
What do they call that? Like it was on the Path Lab. Well, look at where it is, man.
Hmm,
It has like a really interesting name and whatnot.
I don't know, man. I don't know what that is.
Starts with a G.
I cheated, but it's a granuloma.
No, like something
That's
complex.
not a granuloma.
Gone
A
complex.
Gone complex?
Yeah,
That's a Gone complex?
they form like on the peripheries, and
I thought Gone. Okay.
that's usually with like what primary tuberculosis, right?
I think so.
Yeah, but normally like um, yeah, but basically it's just like really peripheral, and it's like one dot. Um, that's like associated with like that's what I was gonna say basically as, but they form like more
Hmm.
towards the periphery. I think they were talking about it like in the path lab too. Like if you look at the pictures, they're always very like peripheral. But yeah, that's it. Hopefully, what did you think, Kenny? You think like it was helpful or what?
I thought this was. I did not realize how much I did not know.
But was it
So,
like easy to understand and whatnot? Like I like
yeah, yeah,
basically
yeah.
no
I think you're
no
thorough.
basically yeah,
Hmm.
know the fissures. Know the fissures. That's gonna help you like localized lesion. Everything I said about what the borders of the heart, like for example, um, on a PA, on a PA, you can only see the right atrium on this side, and then left ventricle and left atrium there. On the lateral,
Hmm.
the anterior border is made out of the right ventricle. The posterior border is made out of left ventricle and left atrium. That those key slices of CT that I showed you, know that, know where the lymph nodes are, and no consolidation, pulmonary edema, and fibrosis. Fibrosis is easy, man. Like that's so just know like yeah, this is what I was saying. Like like what each border has. There's a right atrium, SVC, concave areas, left
Word.
atrium, left
Yeah.
ventricle, um, lateral, like all this is right ventricle, left atrium. Just know that right ventricle, like
Hmm.
I right here, I drew this thing like this is the right ventricle outflow tract, and then yeah, like just know that, and then I think that is all you need at the end of the day, like to you know silhouette sign, so on and so forth.
Hmm.
Yep. And then I'll post this PowerPoint too. Like I think I'll put the speaker notes down below. So it should
Hmm.
help. I think it'll help. Yeah.
Hmm. Yeah.
All right.
Damn, this looked like it took a lot of time to make.
Yeah. Yeah. But yeah, man. That's it. So everybody, good night. Good
Mhm.
night, Kenny. I'm gonna get off. Peace. Let me know if y'all have questions, so on and so forth.